Vou fazer a reunião toda em inglês, porque os nossos convidados, os dois, só falam inglês, então peço desculpas aí de antemão. So it's a pleasure to be here at our grand rounds with such special guests that have been contributing so much with the current research that we're conducting here at the Institute. So without further ado, I would like to call our two speakers who are going to give a joint lecture for us. Dr. Anuraj Shankar, he's a current leader at the Community Health Research Unit at the Oxford University Clinical Research Unit, Indonesia, which is part of the Centre for Tropical Medicine and Global Health, Oxford University in the UK. He's also, he's a lot of things, okay, so bear with me. He's a co-founder of the Open Smart Register platform, which is an open source digital information platform for frontline community health workers. Co-founder of the Genomic Solidarity Indonesia Laboratory, which is a premier genomic sequencing facility in Indonesia. He's a creator of the Summit Institute for Development, which is a leader in community health innovations. His work spans from biomedicine to health policy, with the unifying theme being regulation and resilience of complex systems at the biological, behavioral, and programmatic levels. Has conducted multiple large-scale randomized trial, cohort studies, examining the impact of nutrition, diagnostics, vaccines, and digital health on maternal and child health and early childhood cognitive developments. Most recently, with people here in Brazil, he's co-created the Genomics and Science Dojo and a mental martial art known as Shinjitsu to enhance research and education in science, which he'll tell us about in his presentation. His wife, Dr. Anita Shankar, is an associate scientist at the Johns Hopkins University Bloomberg School of Public Health in the Department of International Health, and she is the executive director of the Self-Empowerment and Equity for Change, the Sea Change initiative at the school, which she will also tell us about today. Over the past 30 plus years, she's been building on her background in biology and medical anthropology, and her research has spanned a range of health and development issues, including women's empowerment, gender-based violence, maternal and child health, HIV/AIDS, nutrition, and human resource capacity building. She leads Sea Change, which we have mentioned, and her research works to lay the scientific foundation and tools for human agency-based empowerment interventions to increase adaptability, secure livelihoods, and improve health. So as you can see, we have two almost like polymaths, so I'm sure we're going to learn a lot today. Thank you so much.
Great, thank you. That's it. I hope you can hear me. Thank you so much, Ilana. Thank you all for this fantastic invitation to be here. And I think it'll be interesting to talk about what changes there have actually been in primary health care and the work we've done in Indonesia, and how to think more about, primary health care as something that is not just an initial service or a curative service, but in fact how it's very critical for preventive and promotive care, and particularly what are the recent innovations in information technology and digital health enabling us to transform that into something beyond what was initially imagined. So let's see here, this forwarding. Let's see, which is the forward. Oh, here we go. Okay, great. Okay, here we go. Okay, so this is Indonesia at a glance. Some of you, of course, may have heard of Indonesia. It's actually in many ways similar to Brazil. Okay. Okay. Great. So yeah, Indonesia is somewhat similar to Brazil in some ways. So it's the fourth most populous country, 278 million persons, but it's an archipelago country, right? So it's spread across 17,000 islands, of which there's probably around 10 main ones, and the main ones that you see sort of up there at the upper left there. So it's sort of intermediate income country. You can see the GDP per capita there. And what's interesting about it is they launched in 2014, actually, the largest single payer system in the world, insurance system, currently covering around 240 million persons. So let's see here. Here we go down.
Sometimes it's like
Let's see here. Maybe I can. I should hold it down.
That might make it go too fast.
Okay, I'll let you be the expert.
No, it's the glitches with having to share it here and also live on YouTube. So
Okay, great. Okay, so let's see. Page down, got it. Okay. So one of the things I wanted to walk you through is that, certainly like many countries like Brazil, there's the challenges with maternal health and and health during infancy. So you can see just the overall view here of the health conditions there and so forth. And one of the things is that there's a lot of gaps in the knowledge and skills of frontline health workers working at the community. So I wanted to kind of start this journey with some work we did in Indonesia a long time ago, actually around 25 years ago, where we were interested in looking at the effects of nutritional supplementation during pregnancy. So normally during pregnancy, the recommendation is to receive iron and folic acid, so all pregnancies should receive that. But we were interested in what would happen if you actually gave women a complete nutritional supplement involving 15 different things: zinc, iron, vitamin B, vitamin E, etc. So we did this large-scale randomized controlled trial, and we enrolled around 31,000 pregnancies. And what this showed was this nutritional supplement will reduce infant deaths by around 18%, would reduce infant death by around 38% if the mother had been anemic during pregnancy. So that was interesting, but and it was subsequently confirmed, actually, by several other trials that were done afterwards. So overall, you can see that this MMS, what we call MMS, which is maternal multiple micronutrient supplementation, basically confirmed what we had observed in Indonesia. So 19% reduction in low birth weight, around 30% reduction in infant death at 6 months of age, and 15% reduction in death in children up to 28 days after birth, but especially interestingly, a larger effect in girl babies than in boy babies. So one of the things we were able to do in Indonesia is that we went back to this cohort 10 years after the initial trial, and we were able to find around 70% of them. So we actually found around 22,000 or so of the kids. And we did detailed cognitive assessment on around 4,000 of those kids. And what was interesting is you could see the long-term effect of this MMS on the kids' cognitive development. So you can see here effects, let's say relatively small effects, right? Around 0.1 standard deviations on procedural memory, and around 0.2 standard deviation effects on general, improving general intellectual ability. So pretty amazing to see this after, 10 years. But I think what was really interesting in this, you can see here on the left-hand side are actually the risk factors, the biomedical risk factors that contribute to the different cognitive domains that were assessed. And you can see there general intellectual ability, declarative memory, procedural memory, executive function, academic achievement, fine motor dexterity, and on the far right there, you can see socio-emotional status of the child. And so overall, the most interesting thing about this is that, as I said, on the left-hand side, you have the risk factors for biomedical conditions. On the right is the socio-environmental risk factors. And what you can see is how much more dominant the socio-environmental risk factors are on child cognition compared to the biomedical ones. So at the same time I was doing this, my wife Anita was doing a lot of psychosocial work. So when I looked at this data, I realized immediately that I'd been doing the wrong thing my whole life, and I should be doing things related to developing people's psychosocial capabilities. And especially on the right-hand side, you can see there, that is the socio-emotional status of the child, and huge dominated effect of the emotional and the psychosocial status of the caretaker. So if the mom is not doing well psychosocially, the kids are not doing well at all. And shockingly, we don't have very many good interventions for this. Actually, we do have good interventions. They're just not a normal part of primary health care yet, which they should be. So the other interesting thing about the study, however, which is a big part of what I want to talk about today, is in this work, doing this large-scale trial, it was integrated into the government health system. So we had to get women to enroll and to go to clinics to get the nutritional supplements. So remember, it's a double-blind, placebo-controlled study. And so we weren't hiring people to go and give the supplements to pregnant women. The women had to participate in antenatal care. So at that time, the government had these community health promoters. And so I asked the provincial governor, I said, can we do open competition for these community health promoters? And he said, I was surprised. He said, yeah, sure, no problem. So we did that, and we got around 4,000 applicants for around, I think, 300 positions or so. So interestingly enough, of these applicants, we had to hire, for every community, had to have at least one community health promoter. And in this open competition, shockingly, not a single of the existing community health promoters were able to outcompete other applicants from that same community. So it meant there was almost 100% turnover of these individuals. Now, amazingly, these individuals performed amazingly well, and we were able to track what's the separate contribution of good quality performance of a lay health worker on child survival in the community. And here you could see that, in fact, if they were a poor quality community health worker, there's basically no impact. So these were the staff that we had hired after recompeting them. So all the existing ones who didn't get the job, they had been for decades essentially of poor quality, probably with very little impact at all on their communities. But in this case, with these new ones hired, if they were average or good, you can see 20 to 35% reduction in infant death in those communities. So amazing, these superheroes of public health are right there living in that community for years, but didn't have the opportunity to create this kind of change. So this really made us think we have to do something that enables more institutionalization of these improvements of primary health care quality. So the senior management team of that large-scale trial launched this institute called the Summit Institute for Development, and you can see their vision and what their goals are and so forth. So it's a local NGO now in Indonesia. And what they decided to do was get into more systematic improvement of community health delivery. And they are a co-founder of this software platform called Open Smart Register Platform that's currently underwritten by the World Health Organization. And at the time we started creating this, around 2014, in fact, there was not an open source information platform for frontline community health workers. There were open source solutions for clinical information systems, but not for community health workers. So they were able to create that with teams across Indonesia, Bangladesh, Kenya, and Pakistan, coding and creating this platform, which was launched and now is active in around 17 countries, which is pretty interesting. So in Indonesia specifically, this is the primary health care from district to hamlet. Probably here in Brazil, I think there's very similar things. And you can see the different frontline health workers there who are involved. So Puskesmas is a health center, like a primary care health center, typically would not be at the village level. There might be one per sub-district, which would cover, typically one health center will cover something like 10 villages or so. And then you see these other, at the village level itself, these other health facilities, which are like sub-health posts. And the thing on the right called the community outreach posts, these are basically events where individuals go to the community and will conduct some sort of event like a vaccination or antenatal care, something like that. And then at the village or hamlet, so you can see basically in each of these locations the different workers that would be involved. So the goal of the work that Summit Institute was trying to do was saying, well, there's these multiple different frontline health workers involved. They're all sort of operating in isolation. And what do we do to actually bring them together so we can change the care from being provider-centered to what we call person-centered care? So this meant that every individual who provides care, and you can see on the right-hand side there, there's this item on early childhood development. So there's essentially 5 workers, now there's actually 7 in Indonesia, frontline health workers, but the goal is for them to be able to openly exchange information to know what each other is doing across a care plan. So this is what we call person-centered care, which hadn't really been invented at that time. So this is just an example of different apps that we created for skilled birth attendants, vaccinators, nutritionists, early childhood development persons, and just an example of sort of the information flows across that. So you can see at the bottom here, I highlight this thing called HL7 FHIRE. So FHIR stands for Fast Healthcare Interoperability Resources, and this is the current data standard in the world that is endorsed by the World Health Organization to maximize exchangeability of information in health servers or apps or whatever it is. So it's currently being implemented here in Brazil, and of course every other country that's part of the World Health Assembly. And the key is you can actually, again, enable data to be fully interoperable. So when we deploy a system like this, with multiple frontline health workers, over a relatively short period of time, you see improvements in antenatal care, and particularly, interestingly enough, you can see postnatal care, which prior to the team-based care was actually not being done. But when you create a team, people start seeing what each other is doing, what they're doing, and what they're not doing. So all of a sudden they started doing postnatal care, but you know, it's great it went up from almost 0 to something like 30%, but still a long way to go. So one of the things we learned from these digital solutions is that a digital solution, probably most solutions in fact, they actually make an average or good quality worker good. Average becomes good, and a good quality worker becomes a super worker, in fact, with some of these type of tools, information tools. But actually, the lower half of the distribution of performance we found with digital tools doesn't really change much. And there's lots of reasons for that, which we can talk about. So this was what we call next generation care, this team-based care. The Summit Institute for Development won an award for this from the World Health Organization, I think a few years ago, as one of the top 10 primary healthcare innovations at the global level. So again, it's how do you take a system that's initially simple, that's intended only for basic care, how do you turn that into something that is more effective and of course would probably be more complex, but then you get this emergent property from a group working together. And I think that's the key there, is how do we bring groups together to work in solving problems in a systematic process, so you get this sort of emergent property. And interestingly enough, this effort by this little NGO in eastern Indonesia was able to convince the World Health Organization that they should create actually what's called a digital adaptation kit for all their various health policies. So the first use case was this antenatal care, in fact, that they had done in Indonesia. And so you can see there's a basic policy guideline that originally would exist in the WHO on the left-hand side. In this case, it's antenatal care policy and delivery care and postnatal care. WHO has these for basically all primary care actions. And so there's this app that now is created, and then WHO created what's called a digital adaptation kit and a reference software, which we have helped to develop, that was based on our initial software, that is fully adaptable to other countries, that has now been ported to the HL7 FHIR platform. So the dream is really something like this, where we're currently putting this in place, where all frontline health workers and facilities are on FHIR, on fast healthcare, interoperable systems, including hospitals and primary healthcare clinics and all frontline health workers. So they're able to fully see what each other is doing, and the patient health record becomes sort of a distributed health record that's accessible from anywhere. So anyone who has authorization can actually look to see the patient who's in front of them, what's the care that they received from whom, for what purpose. If they have a care plan, what am I supposed to do today? I'm the first person seeing this, and I haven't seen this individual before, but I know what their history is and what I should be executing. So this enables us to create district level, in fact, end-to-end information for action, data for action for primary health care. So you see on the left-hand side is essentially these tools for data acquisition. Most of primary health care historically, information systems have been focused on, in fact, reporting. But in fact, the main purpose, usefulness of information, the information age, is actually using information, not just collecting information. So I always tell people, if you're not actually using information, it means you're not in the information age. It means you're just collecting information. So here we have data acquisition and then processing, which actually converts data into the FHIR standard, or you can use apps that are designed on the FHIR standard itself, and they're able to actually ingest data on FHIR from a centralized FHIR server. And you see here this thing called Satu Sehat, which is Indonesia's implementation and design of the One Health system, including the One Health record, where all the health from someone can be accessed at a single source, or even if it's a distributed system, like I've explained to you here on the FHIR standard, it appears as One Health record, even though it might be distributed across several sources. And then those data can go into various types of utilizations. You can have like this, what I call a public health data theater, which is essentially a room kind of like this, where you have several screens and you're looking for each community, in fact, what their health status is, and writing prescriptions, but not drug prescriptions, but prescriptions for action, what can be done to improve primary health care in that place. And every month you're going through, you're doing a grand round like this and looking at that information and deciding what each community needs to do to actually improve healthcare delivery. And also you can drive a call center and other services. We've also implemented this interesting tool that we call data-driven dynamic worker support, where in fact each worker, especially if they're a community health worker that has to provide home visits of some sort, they're actually tracked in real time on a platform, and their assignments are provided for them, and they need to report back. There's a coach for them on the back end if they need some help for something that someone in the home wants some information about something. This coach on the back end helps them and supports them. So this was sort of inspired by our observation and feeling depressed about being able to use Uber or order food and see the car coming to you. But in public health, we were still in the Stone Age where those tools didn't even exist. So we decided to see if we could create something like that. So this was the first kind of a prototype of this, and interestingly, amazingly successful, I would say. So one of the things we do, I mentioned this information use of it, as soon as a visit is done and you have this worker that has an app, that data gets uploaded. And if there was any gap in the care, so this is sort of a customizable care gap text message that gets sent to a person right after they've done a visit. And even during the visit, the care provider will receive this information, but the person themselves receives it. And this is a visit if they're supposed to receive these different services. It'll be highlighted that, oh, you did not receive, blood glucose, or you did not get the hepatitis B assessment, and be sure and get this. So once the client is aware of this, we're able to see these kind of changes that either with messages or without them, you see, certain big improvements in care, particularly here in this location. Actually, glucose level during pregnancy was not being assessed, basically not being assessed at all. But then when the client becomes aware, oh, I'm supposed to get that, it very quickly goes to almost 90%, just because the client is showing up saying, oh, I think I'm supposed to get this service. And so then they end up getting that. So that's the advantage of, again, active use of this kind of information. We also, once you have this sort of digital platform, you can start building other tools on top of that. So one of the things we developed is this technology. We didn't develop it, actually. It's something that we validated. It's called OptiBP, optical blood pressure assessment. You essentially place your finger on the camera of the phone, and it goes through. Let me see if I can just kind of play this. I don't know if this will work. It'll go forward. Okay, great. Oh, there it is, yes. So here's a person, they're placing their finger on the camera of the phone, and the app detects this and starts to then looking at the blood pumped through the finger, and through those waves, those plethysmography waves, it's able to then calculate what your blood pressure actually is, and some other items. So you have this waveform. So this is this added value from having a lay worker or even a skilled worker able to use this. And here we are coming up. It takes around 30 seconds to get this data. And there we go. And your blood pressure should show up. There it is. So this particular person was 138/86. That is not me. And on the right-hand side, you can see the validation of this in pregnancy, whether someone is ordinary blood pressure or whether she's hypertensive or has preeclampsia. In the green there is the ISO standard of performance showing that this actually can work quite effectively. Now, interestingly enough, you have this plethysmography, the waveform there. So we were interested in seeing what added value you can get out of that, in fact. So we applied this process that we called symbolic dynamics. So we're looking to see whether we can analyze heart rate variability and get some added information out of that, since we're collecting the waveform anyway. So we applied this technique where essentially we assign a letter code to each interval, depending on whether the previous interval for the heartbeat was higher, the same, or below the current interval. So you can assign a letter code to each interval based on that. And if you do that, you end up getting sequences like this. So this is not heart rate, it's not heart rate variability, it's the variability pattern of the variability. So you can see these words emerge from this. So you can see GGG, GIC, FIB, FIB. So these are words that are emerging as part of really the adaptive variability that's going on in the heart of that individual. And just to show you that this is a real thing, if you randomly select any of those 9 ones, you don't get these words emerging, although interestingly, GIC shows up, okay? So now you can actually take this information, interestingly enough, and you can link this together to create networks of the words. So this is now the next layer of this, which is what's the connectedness of those words themselves. So you can see here some work done on this. An obese person, their network connectivity of these words is different compared to a normal individual. The normal individual is much better connected. So if there's certain heart rate adaptations, variability patterns, maybe psychosocial states in some way that enable certain variability patterns to support that activity, the normal person can transition to those states more easily. The obese one, they're not able to as easily. They have to go through many more different transition states. So what this actually means from a survival standpoint, I don't really know yet, but I suspect these sort of patterns might be really specific for certain types of conditions. So again, something that needs to be explored. This is the added value of this sort of information collection. I want to show you another interesting example of using information and collecting it and putting it together. So this is some work we did on transforming rapid diagnostic kits, these little immunochromatographic assessments that you use for infectious diseases and other purposes. We thought, what if we can build an app for that to collect that information and to analyze that in some way? So we designed an app that reads RDTs. This was during the pandemic. This is this GSI lab that we launched, which was a high throughput molecular diagnostic and research facility and sequencing facility. During the pandemic, we launched this. So we can capture these RDT images, and we're able to show that, in fact, if we, very simply, if we just analyze the density of the lines on that, the test line and the control line there, we can show that that correlates with the viral density in a sample. And this is very interesting because then on a population level, it's very interesting, we discovered, not just us, but some other people discovered it. In fact, after we discovered it, 2 weeks later, some scientists from Harvard published a very detailed epidemiological analysis of this phenomenon, which is this. The CT value, or the viral density in a swab, actually starts to increase in the population about 2 weeks before the cases increase in the population. So we observed this, so you can see here on week 74 on the upper graph here, the CT value. So when you're doing PCR, for those who are not aware, the higher the CT value, it means the lower the viral density on the swab. The lower the CT value, it means the higher the viral density. So you can see here the delta wave in Indonesia, week number 76. You're seeing here actually a reduction in the CT value, which means an increase in the amount of the SARS-CoV-2 virus on the swab. You see that change happening, but in fact, the increase in cases does not occur until actually 2 weeks after that, 2 to 3 weeks after that, or so you get a peak in the number of cases. So we use this in Indonesia to sort of predict, what is going to happen. And interestingly, you can also predict when that curve is going to come back down by looking at that. Now, from the rapid diagnostic test, you can see here the simulated CT values from that. So we didn't actually capture all these at that time. This is now simulated data based on the CT value, based on this data here of the correlation. That I'm just showing this as something that should be done, that what we would have expected to see, that in fact, in principle, based on the simulation, we would have been able to detect these same things, not just through PCR, but just by harvesting all the RDT images. So again, this is something that probably should be done in public health in general. All these simple diagnostic tests, harvesting these images and analyzing these, you can see on the lower graph there, the same thing. You can see the change in the density of the line, the color of the line. That would have been enough for us to, in fact, have predicted this increase in cases. So again, the added value of getting data, enabling you to turn something that's just a basic system into something that is actually giving you a lot of very interesting information. And likewise here, we can take a rapid test, take it to the lab, a genomic lab, extract information off the immunochromatographic test, and actually map, in this case, for malaria drug resistance. So these are standard rapid diagnostic tests that were actually used during pregnancy or in the clinic to diagnose a malaria case. A sample of these gets sent into a laboratory, we extract the DNA, and we look at the drug resistance pattern. So now we can actually say in a certain area, if you're diagnosed and you have an RDT, and we can read the line density, and we know the place that you are, we can actually predict your risk of having drug resistance. So again, added value from linking all these things together. And this is the most recent thing we've been putting together, which was what we call Genomics for All for pregnant women, which is essentially a woman, comes in for antenatal care. Usually genomics is used specifically to examine issues of chromosomal abnormalities or genetic risk in the child. So we were thinking that actually, if there's a polygenic risk score for any sort of disorder or condition in pregnancy or for the child, in principle, if that's known, can you take action to modify the care plan? So here, basically, every woman gets a set of sequences done for around 600 different genes. We calculate the polygenic risk score, and we change the care plan dynamically on the care platform. So again, this is something that should be done. We're just starting to develop this, so it'll be interesting to see what the impact of that is. So again, you can see the whole theme here is uplifting primary health care into something that is in the information age, enabling all the information that's collected to be used for everybody else. So it's one for all and all for one information. So this is a comprehensive platform of research and acceleration for program impact. We call it NextGen, or next generation primary health care, that you can use to really improve and potentiate any program, whether it's a biomedical intervention program, a psychosocial intervention program, whatever it is, but it's active use of data for action. Essentially leading to what I call the scalable public health empowerment research and education site, or SPHERES. And the goal of this is to reform public health. And so we're doing grand rounds here. I assume all of you here are doctors. And so imagine, so you're trained as a doctor and you do in-class work, right, to get theory of, health and physiology or whatever, and you actually see patients as part of your training, right? And then someone looks to see, hey, are you able to manage this patient? And yeah, you can, so we certify you as a medical doctor. So that seems reasonable that you're doing that, right? So you can imagine in public health, that system doesn't exist. We train people in the classroom and say, go out and be a public health practitioner. So it would be like you getting classroom instruction and saying, okay, go out and care for a patient. So you would think that's crazy. But in public health, that's normal. We love that. So that's why it's so backward. And so the idea here, now why is that happening? So it's happening because in public health, the stethoscope, so to speak, is the health information system, which is dysfunctional in most areas. So if you can strengthen that, now all of a sudden you can actually create public health practice, training in public health practice. So not only do you get programs that you can scale and manage based on information, you can do a grand rounds of every community, what's actually happening, writing prescriptions for them, action prescriptions, but you can actually train people in evidence-based public health implementation. So that would be the first in the world. It'd be great to see that come from here as well. And you can deploy interventions at scale, right? So in a very short amount of time, if you can deploy these interventions at scale. And then I want to present to you briefly this issue of genomics and science dojos. So Dr. Daniel Fattori, who's here with us, and another colleague from Brazil, Felipe Argolo. I was on a call with them just talking about different things that they were doing, and they said, oh, we're doing this thing called the Science Dojo. So I thought, oh, that's interesting. So they explained that to me, and I thought, hey, that is really a cool thing. Is there a way to make this into something to train scientists more in Indonesia? Because in Indonesia, most decisions are still evidence-based decision-making. There's not really evidence. So the most important in the room, their decision prevails. Other people don't really speak up much because they're afraid or don't want to upset the person who's in control. So there's no real science practice or evidence-based decision-making. So we thought, let's make a safe place. So Daniel and Felipe and I discussed this, and we thought, let's do something. Let's make a safe place, a dojo, and where people can come, and we'll create this new sort of combat sport, intellectual combat sport that we called Shinjitsu. And so the goal of Shinjitsu, it's sparring. So you join the dojo and you intellectually spar. It's like debate, but I would say, more aggressive. And and we integrate knowledge and critical thinking, positive psychology and empowerment, and persuasive language. How do you do that? How do you talk to someone and say, no, that's not right, it should be like this is what I think, this is the reason. And then we created this arena for Shinjitsu, where you have, Team A and Team B debating, you have a screen there, and you have judges, and you get real-time scoring, how your team is doing. You have the audience there. So this actually is a flow of the Shinjitsu match itself, the match flow. You basically can see there, the Team A presents for 2 minutes, and then Team B assaults them, and then they have to defend themselves, and they get scored different points. And then there's a break for coaching in between rounds where you can get, refreshment, get your, a pat down or something, make sure you're okay. If you have a cut, someone can, take care of that. And then the second round, takes care, yeah. And then you see who wins the match. So I think here's a little video of this.
The issue is that in research, it requires a continuous, conducive environment. An environment to talk about your mistakes, to talk about your questions, to talk about whether the answers that you have gathered is something that is believable, something that is correct, or something that needs to be questioned even more. And that kind of environment should be provided by something like the dojo.
So we're working together in this project specifically to improve the human resource the overall or the general idea about this kind of workshop. I think it's important, especially for scientists in Indonesia, because this can really transform the way of how we actually do science in Indonesia.
It's amazing what they were able to do in a short amount of time and really transform themselves from good scientists into great scientists. The type of scientists that can have great impact and change the world, both from their local communities to the global level.
So yeah, that's the quick overview. See you at the next Genomic Science Dojo workshop. Daniel will be there, right? Okay, great, interesting. So that was amazing to see people. What I noticed is the tournament activity that really got people to openly debate, and we had students debating with professors, and interestingly, a student won. Actually, my doctoral student won the first Shinjitsu tournament in the world. So thanks to all collaborators. Actually, these individuals and hundreds of others really make all this work possible. And really, I'd like to give a shout out to Daniel, who has really been inspirational for a lot of the work that we've done. Some of the early work, in fact, on the digital healthcare, and also, of course, on helping to create this dojo. In fact, the Shinjitsu was inspired by Brazilian Jiu-Jitsu. So thank you for that. And over to Anita. So thank you. Yeah.
Hello, and thank you. I always learn something new when my husband gives his talk. I'm going to bring it down to slightly a different level. As Ilana had mentioned, I come from a background of biology and medical anthropology, and most recently my work has been focused on human agency. And so what I'd like to talk to you today about is how do we use the power of personal agency to transform healthcare delivery. Let's see if I got it. Okay, so what is the challenge? So when Anuraj was here, he was able to demonstrate the number of gaps in public healthcare and how we haven't really been focused on how to get the information to the people. But what I'd like to talk about is how do we get the people that are doing the frontline care to be more engaged and more intentional and more accountable so that they can actually provide the services that they need to. So in primary health care, it's critical to empower frontline workers and the populations themselves. So the frontline workers can do their job better, but the population also can ask for the services that they need. And now research has shown that personal agency is a central component of empowerment and required for behavior change, but there is a lack of interventions that incorporate evidence-based personal agency empowerment approaches into their programming, in healthcare programming and development programming, even for empowerment initiatives. So what's agency? So we use the psychological definition of this, and that's the ability to define one's goals and act upon them. But when we think about agency, a lot of different words come up. Oh, we talk about empowerment, goal setting, action, self-determination. What I'd like to talk about is personal agency, and in that sense, it's that internal psychological capability to envision and navigate toward a positive future. And because of the various different separations in medical traditions and public health traditions and sociology and anthropology, the psychologists don't always talk to the public health practitioners or the anthropologist. And so this idea of internal psychological capability is kind of set aside within the mental health realm. But the fact of the matter is, all of the learnings from psychology has direct relevance in how we function every day and how we do our jobs. But we rarely have access to this information. And that's what our work in personal agency is designed to do. So what does this look like in a real life setting? So here's a young woman, Nikita, she's a healthcare provider, and we provide her with resources, with information, proper nutrition, electricity, apps. We even have her be able to go to school and get the schooling that she needs. But does that actually lead her to be a better healthcare provider? Does it provide her with that empathy, accountability? Is she attentive? Is she innovative and respectful? Usually not, and that's in large part because her own experiences, her beliefs, her thoughts, her emotions, her past behaviors determine actually what actions she takes in the future. In addition, and I'm sorry the slides aren't coming up, anyway, it's social relations. So we think about our lives and how we function in the world in large part by the people we are surrounded with, our histories, how we think the world is supposed to work, and that's how we behave. So the idea of personal agency is really to help individuals understand how they make decisions, the relationship between their thoughts, their emotions, their past actions, and how that determines their future actions, and allow them the mental tools and basic exercises to help understand what it is they want and how to create the mental models to be able to get there. And that's what we do at the Self-Empowerment and Equity for Change Initiative. Our goal is to catalyze agency. It's in an international development, but actually it has relevance for anyone who's human. We have three primary pillars of our work. We have a large practice program where we do training of trainers globally. We also do randomized controlled trials to provide the evidence based on also the thought leadership around personal agency, as well as looking at how we can use information systems to create innovations and get to scale. Well, our scientists in public health focusing on personal agency interventions, actually not as much as we would like to. We did a scoping review of over 4,000 articles that we narrowed down to 32 for review. And we were trying to look at anywhere in these papers that they talked about personal agency or personal agency interventions. We looked in sector areas of entrepreneurship, gender equity, environmental sustainability, and health. And we only found 3 that had interventions that explicitly focused on personal agency. But we hope with this work we're going to be able to build more momentum for scientists to be able to explore this further. Now, as a result of the scoping review, we found that most of the interventions were in entrepreneurship and gender equity, so kind of completely outside of health. Fewer in sustainability and focused on high-income countries. Women by far are the most targeted group, and usually within the context of gender equity interventions. And most people talk about agency, but they don't really talk about interventions to foster or develop agency. So there's a significant lack of interventions that are supporting the development of personal agency. So what type of impacts can we see with personal agency interventions? And I'll talk a bit more about what we actually do in the intervention, but I can show you the results from some of our randomized controlled trials. Now, none of these, except for one, are actually within the healthcare system. But it does give you a sense of what is possible. So we ran a randomized control trial to enhance the sale of cook stove entrepreneurs in Kenya. And on the graph on the left, it's looking at the health of that business over time. And selling cook stoves is a very arduous process, and we saw a lot of drop-off over time. But the red line indicates those who got just empowerment training. This is just psychosocial exercises together in a group. And the other group got business training, actually. And so you can see here that over about a 9 to 10 month period, those who only got the psychosocial empowerment training, more than double of the number of businesses were still functioning at the end of the 9-month period compared to those who had gotten the standard business training. And on the graph on the right, you can see, again, sales were really difficult in the first couple of months, and the big shifts between the red line, which is the group that got the empowerment training, and the blue line who got the business training, was related to incentives associated with maybe taking a little risk. So at each of these kind of pivot points, where the scales kind of diverge, the people, all of the entrepreneurs were given the opportunity to get cook stoves at a wholesale price, but they would have to take the risk to buy those and actually sell more cook stoves. And what we found is if you had the personal agency training, you were more likely to take those risks that ultimately led to greater growth and greater income generation. We also, in a completely different surrounding, conducted a randomized controlled trial with over 1,000 partnered women in a humanitarian setting in Rwanda. And here, again, these interventions are fairly short. This was a 2-day training for the women and 1 day for their male partner, with the hope to see if there could be a reduction in gender-based violence. Now, before we get to the gender-based violence impacts, what we were surprised to see, even in a humanitarian setting, there was a 25% increase in starting a new business. Actually, there was a 34% increase in income in the past month, 60% increase in developing new skills, and if the male also participated in the personal agency training, a significant increase in intra-household task sharing, whether it's taking care of the kids, doing the dishes, or preparing meals. We also did see a reduction, about a 30% reduction in intimate partner violence, especially those who had experienced it by baseline, but we also found a 35% reduction in non-partner violence, which was a bit surprising. And from the qualitative research, we found out that that was mainly due to the fact that people were getting along together better. So their disagreements with their neighbors were reducing significantly. Now, in this particular population, we did not find a significant reduction or change in self-efficacy or decision-making. And also, there's a slight increase in self-reported anxiety and depression, but again, the rates were quite low, and it could, because it's a humanitarian setting, there could be a number of different factors related to that. We also combined a personal agency training with a mobile health intervention in India to see if we can help the HIV outreach workers to enhance the antenatal care for the HIV-positive pregnant women. And when we combined both the behavioral and the mobile health intervention together, we found that the outreach workers had greater self-awareness, they had more confidence, they also had better interpersonal relational skills, and their patients felt more empowered to be able to take advantage of the health care that they needed. So it was quite encouraging. We're also in the process of doing a large-scale randomized controlled trial now in Uganda with entrepreneurs. A lot of the work around goal setting and enhanced action comes from the entrepreneurial and the development sector. All right, so what I'd like to do is tell you kind of what we're trying to do with our personal agency training is try to shorten this opportunity and action gap, because oftentimes in our lives we have a number of opportunities that are available to us, but because of uncertainty, fear, stress, lack of self-esteem, lack of self-confidence, and a number of limiting socio-cultural norms may prevent us from taking advantage of those actions. So we really feel like you can be provided with the resources and technical skills and opportunities, but without the personal agency, that's like the missing piece in being able to take advantage of that. Our work at Sea Change has looked at integrating agency as a key piece to accelerate outcomes in women's empowerment programs within environmental sustainability and health and livelihoods and entrepreneurship. So I'm just going to give you a few examples of exactly what it is that we do. So we start with a very personal journey by helping people understand the think, feel, do cycle, having them then understand who they are now through this tree of life. So their roots are all of their past experiences that kind of got them to here today, to this place today. The trunk is who are the people around them, their present, where do they live, and then the fruits are the achievements that they have made, and then the buds are those hopes and dreams for the future. Because what we find is most people have never had the opportunity to ask themselves, what do I want for my future? What are the things I want to move toward in an intentional way and a clear enough way so that they know what next steps that they want to do. So here is where the big work actually happens. Once we kind of look at our buds and our hopes and dreams, we often notice that the first things that come into our mind are all the reasons why we cannot do what we want to do. So understanding those limiting beliefs and then being able to create strong reframes are important. Now, for all behavior change activities, we want these to be embedded in people's values and kind of core beliefs about themselves so that they're quite directional in a positive way in their life. And we also want people to understand that these issues are not just about how I am in my work, right? Because this is not just a job. How I am with my relationships, how I am with my community, my health. To understand that all of this idea of personal agency affects every single part of our lives, and there is no separation. There shouldn't be. And so sometimes when we look at balance and think about work-life balance, it's actually balance in life based on the goals and the visions we have for our future. And again, none of us, well, not none of us, but very few of us even think that these are thoughts that we should be considering, or we should take the time to reflect on this. So this is where we give people the opportunity to do that. Also, in order to be able to enhance our agency, you have to take action. So being able to identify the next proximal action you're going to take and assess whether you were able to do that or not allows you to build that agency over time. We're really looking at sustained growth, not just kind of catalytic growth and then kind of falling back to old patterns, right? So, and each of these programs are modified with cohort-specific, to address the cohort-specific challenges. We need to do it in a group because at any point in time, one's individual agency may be low, but with a group, you can build on the collective agency of the group to help support the individual agency. It's usually 16 to 24 contact hours. We're not talking about an extended 6-month program. So it's really what we think of really a transformative process. And we use a number of dynamic methods, mindfulness, visualization, journaling, and we have a number of low literacy options as well. The key is to have them develop this ability to sense their lives where they are, shift and reframe, and then act in a way that's proactive and with SMART goals, so they're very specific, time-bound, etc., and to take growth steps toward their work and life visions. So they should be able to understand when they feel lost or uncertain how can I be more self-aware? When I feel stuck or doubtful, how can I reframe this to move me in the direction that's important for me? And then how do I act? So when I have to say or do the right thing, what's the best path for me to be able to do this? In general, we like to pair and integrate this with technical training topics because you can enhance your agency, you can feel excited about being able to reframe, but then you really need to be able to take action in order to continue to build that skill. And we want people to really think about how this can apply in various different areas of their life beyond the technical focus. We've also found this to be particularly important when we're having difficult conversations, for example, around gender equity. Why do we need women in a particular leadership space when sometimes people will be resistant to, we don't need to change the structure, etc. By grounding this on how each of us can flourish more for ourselves and together, our differences become less because we're working from the perspective of the fact that we're all humans trying to do the best that we can within the life that we have. So then we can more easily discuss issues of gender inequality and discrimination. Sea Change has worked in a range of different program activities, enhancing the role of women in male-dominated industries. We've worked with the National Renewable Energy Laboratory, Women in Systems Transformation, so kind of at a systems level, but also enhancing entrepreneurship, livelihoods, and also health. We have a number of open source manuals targeted at entrepreneurs and employees. You can come to our website anytime and you can download those for free. We also have recently focused on a more trauma-informed personal agency training because we work with a number of care workers who deal with gender-based violence, and so really it's focused on victim advocates as well as care providers in high-risk settings. We work with youth. We created the Be Best program, which is a focused business and personal agency training for actors in the sustainable waste management or solid waste management sector in the Philippines and Indonesia. So all of these are quite adaptable. The key is, before I go into that, is building local capacity around these concepts. Because if I go and try to do a training in Indonesia, it's unlikely that the ideas or the stories that I have to say are going to be understood. So being able to continue to build local capacity of trainers around these concepts who can then deploy it at any level and adapt it according to the populations that they're working on is really important. We have over 300 trainers globally in 24 countries. We've worked with over 120 organizations with a general reach of about 140,000 individuals who've been trained, but we need to build more trainers and integrate these personal agency trainings into all types of health and development activities. We're also working on various different innovations because even for our trainers, we know we need to maintain the fidelity of this training. So if we're going to be able to reach scale, we are experimenting with a number of AI models and to be able to, either through chatbot-assisted scenarios, help the trainers understand the concepts and process and customize these ideas so that they can be more effective. We're also using digital messaging as reminders and for mentorship and coaching. The idea is to be able to reduce the overall cost to get these key concepts out to more people. Okay, so ultimately our goal is to support dynamic interventions that center on people, being able to really focus on, as we've got the apps and information age going on, how do we build the human age for ourselves and build our own agency to create the lives we want and also be able to serve better others in more impactful ways. All right, so that's all I have for now. Thank you.
Thank you so much, Anita.
Oh yeah, this is our team. This is some of our team anyway. I wanted to thank them as well, and thank all of you for the opportunity to be able to be here.
Okay. Okay, so I'll invite both of you to come over so that we can have our commentary. I don't know whether to say this in English or in Portuguese, but I'll go with English. So Professor Paulo Rossi, he's a doctor, graduated at the Federal University of São Paulo, has a master's in epidemiology and PhD in psychiatry at the University of London. He's a full professor at the Department of Preventive Medicine at the University of São Paulo, scientific director at the National Center for Mental Health Research and Innovation of the University of São Paulo as well. He's also a full member of the State of São Paulo's Academy of Sciences, and he'll be providing commentary for both of these talks.
First of all, I'd like to thank for the invitation for this very challenging task of commenting about what we just had seen. And I would like to thank Anuraj and Anita for amazing, wonderful, and provocative presentations for us. I think they are apparently they are opposite, but just apparently, because Anuraj brings us with the technology and experience in Indonesia that we need to really take advantage of all the technological and innovation developments that we have had in the last decades, and for changing completely the paradigms of primary health, not only primary health, but public health care of populations. I was really very excited about everything I saw, because I've been working with public health for some decades. And also, I had the experience of being in the front line for the actions and policies from the state governments in São Paulo to lead with the terrible challenge that the pandemic of COVID-19 brought to us all. I was the coordinator of the scientific committee to advise the government for actions regarding the pandemic. And the first great challenge that we had was exactly how to get real-time information in order to assess what was happening and be able to guide what we should do. And we had, for example, to create a very, how can I say, very simple surveillance system, because our surveillance system, as well as all the other surveillance systems in the world, were created in another era when we didn't have the development, the velocity that we had of things happening and changing that we saw during the pandemic. So the surveillance systems were all very obsolete to be able to bring the information we needed to deal with the pandemic. So in São Paulo, we created a new information system based on information that came from all the hospitals in terms of patients admitted. So we could see, at least, with a lag of only 1 or 2 days, the number of people that were admitted to hospital due to COVID-19, and we had nice curves to assess the progress of the pandemic and also the impact of the measures that were taken. So the examples that you brought to us, having the primary care as the first and probably most important source of data, and we already have all this, what's needed to implement this. And one of my questions to you, Anuraj, is whether this has already been fully implemented in Indonesia, because this is the huge challenge for us. I know that our Minister of Health is investing very, very hard on the FIRE as the platform for every digital innovation, and also the system, the health information system that we have in Brazil. So I'm hopeful that in the near future, Brazil is interesting because I thought that we had the largest primary care network in the world, but today I was convinced that Indonesia is doing better.
I don't know.
But we need the first. And our model is also very robust and powerful. But we're still lacking the information system in order to guide policymakers, to guide policy managers and providers, and what I found so interesting, to guide patients and put patients or citizens in connection with the healthcare system, really. So I was really so provoked by, and I hope that we'll be able to, from today, start exchanging ideas and experience. For example, we've been working with digital innovation in mental health care, which is still not putting in the right place in terms of public health priorities in most places, in most countries. I think it's right to look at the maternal and child health first, to make sure that the development of the children is guaranteed and improved. We also at CISM have an intervention. We're testing and implementing an intervention for high-risk young and pregnant women from low income groups in society. in order to give a better chance to the children that will come from these pregnancies. But I think that mental health, at least in Brazil, and it's interesting that yesterday I received the list of the roundtables for the Brazilian Congress of Epidemiology that will take place in November, and there is no mental health at all. And it's a shame. I mean,
Absolutely.
so I think that what we're doing with digital innovation, we're already thinking about this platform. It needs to be integrated in this platform. So I agree that we come from this idea that primary care is a simple delivery of care. We use here in Brazil the expression postinho, which means that the primary care clinic is a small house that does very simple interventions like vaccines and maybe prenatal care, but primary care is very sophisticated and can be so important. It's basic in all the network of care that populations need in order to thrive. So it was fascinating to see your talk. Thank you. And Anita, she brings another side to which is not less important than all that technology can bring to us to improve care, which is empowerment of each one of us. And I was wondering whether this kind of skills and resources, internal resources, whether this shouldn't be what we teach at fundamental, at basic school.
Absolutely.
Because
That's correct.
everybody would
Absolutely.
need to, and I think that it's not only health promotion, it's much more than that. I was really fascinated, but I think that the main challenges, or maybe some of the main challenges, are how to scale it up. And you brought in your last slides the issue of how using digital technology we probably will be able to have a structure that helps us to scale it up at the level of, for example, a country or large populations, or populations that are of difficult access. I have a student here, Isaac, who comes from the Amazon region. He lives in Manaus, kind of retired there. And he is always worried about the riverside populations in the Amazon region. They don't have access to anything. And but with technology and with empowerment, probably their lives or the quality of life will improve a lot. And so I'll stop here because I was really taken by surprise with your presentations, but I think that it made my day. So thank you very much, and I'll stop here and open to questions for the audience. Thank you.
Yeah, thank you, Paulo.
Thank you, professor, for your commentary. A gente abre para perguntas. Se alguém quiser perguntar em português, a gente pode traduzir também sem problemas. So if anyone wants to ask in Portuguese, we can translate. Did anyone have any questions? Yes?
It's not really a question, but more so a
Introduce yourself.
Oh, sorry. My name's Catherine. I'm from GW Medical School, and I'm here doing a research summer. And thank you, everyone, for being here. I actually think it's funny or interesting that you said that the two lectures were opposite. I actually found that they were very similar because with your lecture, you're actually providing agency to the healthcare workers in Indonesia because you selected the people that had a goal that they wanted to achieve, and then you gave them the resources to achieve that. And then also, like, with the whole healthcare system in general and providing agency to the people in Kenya and the other places that you worked in, I found that there was also opportunity to increase health literacy. Mm-hmm. And that's something you can also do with like digital apps and stuff like that. I think that's like the next step. So I was also kind of wondering if that was one of your goals as well.
So yes, we are bound by agency because we understand the importance. Oh yeah, sorry. We are connected through that desire to really have populations flourish. That means every person in that population, whether you're a healthcare provider or you're a receiver of that healthcare or development program. And you can get an agency through various different mechanisms. And all of these connected information systems are really critical. And being able to understand who we are is very fundamental, and I do believe needs to be integrated in our school systems. That is one of our goals, to be able to work at a larger venue, just kind of not just development program activities, but through how we teach our young people how to create their lives. And I think the challenges, but it's like often mental health, it's kind of a soft skill. It's kind of this is nice to have. But these are not nice to have skills. These are foundational to who we are as humans, and we often forget that in all of the heavy, busy, technical work that we are engaged in. And I think the more of the voices that are, reframing that and saying, listen, we have to build who we are. We have the technology, we have the evidence, we have the various different tools, but we have to work together. To be able to do that is going to be really important. So it is really we need to build this momentum around agency building to integrate information technology and also at the same time human agency.
I completely agree, and I think that when people at my school, it's like heavily focused on public health, and so they always remind us that prescribing medication, diagnosing is has only a 20% chance of improving a person's health. Like 80% is like outside of the office. So, I think that providing these like opportunities for people to be empowered, providing agency, is kind of the main root of improving population health. Because if you don't have the agency to seek healthcare, you're not gonna go to the site. You're not even gonna meet the healthcare worker. If you don't have the knowledge that that's what you need, then you're also not going to be able to. And then also looking at mental health, if you feeling empowered and having the agency is going to improve someone's mental health and in the end produce better health outcomes. So I think that's really awesome, and both are equally important.
Thanks. Yeah. Do you want to add anything more to that, Anu?
No, I agree with everything that was said. I think that one of the strange things, so I was at the World Health Organization for several years, World Health WHO in Geneva, and what was amazing is that, we had so many policies on biomedical interventions, but there was very, very few policies on psychosocial interventions. And one of the reasons for that is our paradigm for creating these policies is basically evidence, and the main evidence, of course, is RCTs, randomized controlled trials, and large-scale randomized controlled trials. So I think what we really need to do, this most critical aspect of humanity, I don't know, maybe sometime around 300 or 400 years ago, 500 years ago, we started defining human beings as biomedical entities. That was probably our mistake. But so we are primarily, in fact, psychosocial entities. So I think if we can reframe that a bit and start generating the evidence necessary. So how do you make a great human? Not biomedically, that's part of it, of course, but psychosocially. And so I think creating these interventions, doing these at scale, seeing what actually works, that'll get us to the point where we can actually be in the age of humanity, maybe, which has not yet happened. So I think that's what I would really try to emphasize, that how we can really create this evidence at scale that we need. And it is amazing that I look at, like I say, my big epiphany when I was looking at our 10-year follow-up data, I was like, oh, wow. All these psychosocial aspects were so much more important for these kids than the biomedical ones. And then I was looking at the data from Anita that she had showed on these agency interventions and looking at the outcomes of those, income of the household, welfare and so forth. And I was thinking, there is no biomedical intervention that has anywhere close to those impacts. So I think, this is where I think we really need to, pivot. And now's the time to do that.
I don't have a question.
Yeah.
Sorry, my English is a little bit rusty, but my name is Isaac.
Great.
So I think work with mental health, it's a good thing, but in this kind of people that don't have access to internet, and it's a little bit dangerous. Because some people don't even know what is insomnia, depression, anxiety. So sometimes I think, how can it, and in my state we have almost 4 million people and just 60 psychiatrists. And so sometimes I think, how can we manage this kind of thing? Because we're gonna talk with people that don't even know what anxiety is, depression is, and say, hey, I think you want to make suicide. So sometimes I think, how can we manage that?
Yeah. So that's a really important question, and the populations that you serve have various. They come from such a different background and mental models about their life. Maybe one thing that may be helpful is to be able to have these tools, these psychological tools, either coming from positive psychology or various different psychological traditions, to people on the ground who live there every day, and identify how you can take these tools and help engage with other people on helping to build their agency so that they can at least become aware of what's happening to them. Oftentimes we feel like we have no control over the thoughts in our mind, or we have no control over the ability to change that. But that's not true. Absolutely we have that capability. But we have to do that. So bringing some very fundamental knowledge around that connection about the thoughts that you think in your head, the feelings that you have, why do you do the things you do, just at a very fundamental level may help them understand how to have more control over what's happening to them, and then potentially recognize, okay, yes, whenever I'm doing a stressful thing, I'll have anxiety, this is still okay, but what are the guardrails when I maybe am in a more serious situation or I need to get get help. But it'll take time, but it's completely doable. Anyway, but having people on the ground in these villages that, for this population of 4,000 people, that can learn these types of skills and be able to communicate them, I think is going to be important. Do you?
Yeah, I'd like
please.
to make a comment that we need to look more deeply into how is the situation in each region, in each area. So, for example, the state of the Amazon has 4 million people, but 2 million live in the capital, Manaus.
I see.
So, and at least another million live in kind of mid-sized towns. They are urban citizens, so they have access to our primary care network, for example, most of them. So we still have between 500,000 and 1 million people that are really living in areas of difficult access, and we need to think about how to take care there. But we have other challenges. For example, the 60 psychiatrists in the Amazon, they are all based in the capital, in Manaus. So we need the technology in order to take mental health care to the other 2 million people. So I think that for each case, we need first a diagnosis, like whether there are villages of 4,000 people or towns with 60, 70,000 people, and this large urban center, which is Manaus with 2 million people, which is larger than most European cities, for example.
I think that a couple things that I would agree, with what's already been mentioned. I think that if there's a way to develop this infrastructure at the primary healthcare level, where you're actually able to have a greater level of skills there that's necessary to help deal with some of these problems, that would be important. Now, when I've suggested that previously in many places, usually the pushback, especially from psychologists or the psychiatrists, is they say sometimes, well, this isn't like giving a vaccine or giving a pill, right? This is a more complex type of thing. And I think that is true. It's also true that maybe it's not as complex as thought. So where's the middle ground there? That in fact certain things can be done. What a layperson or a semi-trained person, what can that person actually do to support these sort of health services? Because the psychosocial health of anyone, the mental health, as mentioned, extremely, extremely important, probably more than anything else, really affecting how they can thrive, what's happening in their life. So I think that's one thing I think is really important. The other one is that actually, I often remark that I believe as human beings, we have superseded our biological selves, and the real human entity is in fact the culture. So that's the life form, in fact. And so if you look at it that way, there's many of these different cultures. So I think cultural transformation, I think, is very important as well. And that's part of what happens, in modifying the belief system of someone. And really modifying the belief system, it's not about changing their belief system to saying, oh, believe A or believe X. It's actually about enabling a set of tools for them to innovate and create new frameworks of culture or belief systems. It's the resilience, actually. And so I think that is an important thing to think, how do you open up people's mind at the household level, at the community level, to create this kind of change? And I think Brazil, one of the most fascinating examples, I'm sure you're all aware of this, is what happened in education in Sobreviverao, that essentially a cultural change around the importance of education. Yeah, they did things to improve the schools and so forth, but I think really, the cultural change around education was important. And I think that's something we should start thinking about too, from a mental health standpoint. How do we create a cultural change around this, mental health? People talk about, toxic behaviors and so forth. But I will mention this interesting quote from this physician his name is George Canguilhem. My favorite quote actually about what health is, which is that health is being able to fall sick and recover. So it's not that you don't get sick, but in fact you have this resilience and you're able to adapt and so forth. Likewise from a psychological standpoint, it's not about insulating yourself from adverse events or stresses. It's not really about that. Yes, toxic stress is not a good thing, but how do we culturally sort of change to think, okay, listen, you've got to challenge yourself. How do you do this in a way that builds your adaptive and resilience type of capacity? And maybe those sorts of skills, a frontline worker, a primary healthcare worker could probably, assist with that. Very good question.
Well, we are
Nice time, by the way.
Yeah, we are sadly running out of time. Professor didn't ask any questions because it looked like you want to ask a question, but we are past noon already.
Okay.
But if anyone wants to chat for a bit, ask a question after we're done with the transmission, I'll sure be doing that. So, thank you everybody for being here. Thank you guys so much. It was really informative. It's such an interesting theme and unusual thing for us to be talking about primary care within the institute. So I'm very happy to see that. Thank you.
Excellent, thank you.
All right.
And
Wonderful job.
if you want to share,
The slides.
my email,
Oh,
my
yeah,
WhatsApp,
email,
and the
yeah.
slide,
Okay.
yeah, that's
Okay.
totally okay. Yeah.
Let's have lunch.
Yeah.
Yeah. You guys have time.
Thank you, Paolo. Very nice.
You guys have all your things here?
Yes.
Yeah.
No,
So we meet downstairs.
What in general? What are the things that take place in the journalism? Because that's something that I really want to do.
You guys
It's
gotta do it
very
here.
difficult.
Good.
It's so difficult to get people
There's a
to
dojo
meet
master.
each other.
There's a dojo master. And the other guy is Felipe Argola.
You, Danielle.